All right.
Okay, everybody, so we're starting with chapter 14 on eyes. You've just taken your first exam. So this content will be on exam 2. I put myself on the screen because I feel like there's things that I needed to maybe show you as we're talking. So I kind of shared the screen with PowerPoint. So objectives for this, oops, objectives. Okay. Objectives for this chapter is identify the external anatomical features of the eye, describe the internal anatomy of the eye, the functions of the ciliary body, the pupil, the iris, compartments of the eye, identify structures viewed through the ophthalmoscope, pupillary light reflex, fixation, accommodation, age-related changes, most common causes of decreased visualization in the elderly, and incorporate health promotion concepts when performing the assessment of the eyes. So start with inspection all the time, right? In health assessment, we start with inspection. So again, I want you to take away from this what you're going to be doing with your patients, because a lot of the stuff on the eyes in this chapter is stuff that they would be seeing their optometrist for or ophthalmologist. So, but you as a nurse can start with inspecting. You can look at someone's eyes, the internal structures and the external structures, and note if there's abnormalities. So you look at their eyes, you're looking at the sclera, the white part. You're looking to make sure both pupils are looking at you. Now, in this condition, you're telling them, close your eyes. Let me see. Now, you might not know what this is when you're looking at it, but it's actually called a xanthelism. And what that is actually cholesterol deposits on the eye. So if you looked at this patient, again, you don't know what this is. You haven't had all the pathophysiology of these diseases yet, but you can look at that and say, well, that shouldn't be on the eye because I know what a normal eye looks like. So when they get these little patchy things, it's actually their cholesterol levels are really high and they start to form on their eyes, their eyelids. So looking at this eye, you can look at this, and probably many of you have had this. You look at the lid, and you would call it a sty or, a non-medical term, but they're actually called a hordeolum or a chalazion. And the sty, the other name for it is the hordeolum, which usually means an infection. So something in there has caused like an infection, and you might get some antibiotic cream. A chalazion is usually a blocked tear duct, which causes it to look, and sometimes they kind of look similar. So once again, you're looking at that eyelid and knowing that something's wrong with it. Internally, the sclera, you all know that's supposed to be white because you've seen eyes where the sclera is white. In this case, it's yellow, so that would indicate that there's possible jaundice or something wrong with the sclera of the eyes. So once again, inspection, strabismus is actually misalignment of the eyes. You may see this in kids. They call cross-eyes, what they used to say in the past. Sometimes the eye's fatigued and it drifts over. And it's related, sometimes it can be related to a nerve issue, but some cases it could be a muscle weakness because you actually have muscles that we'll talk about later. In this case, look at the eye. It's all red in the sclera and even on the outside. So that's what you call pink eye or conjunctivitis. So that can be bacterial or viral. But you're looking at the eyelid. Is it red? Is it swollen? Are there any infections? When did these occur? What time of year? Okay, this term, I actually put this in the beginning of the slide because this is something as nurses you will need to know. I do clinicals sometimes with students, and this is something that they'll document. And usually when they write their nurse's note, it'll begin, receive patient at 7 a.m., awake, alert, and oriented. We did this last class already. Remember we said they're oriented times 3, to person, to place, to time. They know their name, they know where they are, and they know what time it is. And then they also write the acronym PERLA. So what does that mean? Pupils are equal, they're round, they're reactive to light and accommodation. So you can look at the person's pupils and say both pupils are the same size and they're round. So you can do that with inspection. Now, how do we check for light and accommodation? So the way we check the light reflex, I don't have a pen light on me, but we use a pen light, and we actually bring a light in from the side like this. We bring a light in from the side, and we watch that their pupils constrict. And what happens is there's normal constriction when that light is brought in from the side. And then there's a consensual reflex, is that the other pupil will constrict as well. So if you look at this, the pupils are dilated, and then as we bring the light over, the one will constrict, and then the other one will simultaneously constrict. So if we've measured that, and it does that, we call that, and you can be practicing that in the lab, we call that the light reflex. So the pupils are reactive to the light reflex. So what's really going on in your brain when that's happening? Well, this occurs because of some cranial nerve activity. And the next time we meet for lecture, we're going to be doing neuro. So we're going to be doing cranial nerves. So I thought it'd be good if we kind of get a taste of it now. So this occurs because cranial nerve 2, which is the optic nerve, carries the sensory message to this, and then synapses on both sides of the brain. And then the motor efferent path, which means the exit, efferent exit, cranial nerve 3, the ocular motor, causes the constriction. So I'm going to explain this again on another slide, but kind of think of it like when you go to the doctor and they do the knee-jerk reflex. Like they take a reflex hammer and they hit your knee, and that sends a signal up through your brain that causes your knee to kick out. So the motor part is your knee kicking out. So that's what's happening with this light reflex. So you see here, we put the light in, and this is cranial nerve. The red one is actually cranial nerve 2, which is optic, and it's taking the message in. And remember, the back of your brain is your occipital lobe. So it's taking that light reflex in, and it's bringing it around to the other side of the brain. Okay, so actually, let me just stay on this side. So it's bringing that reflex in, and it's sending it over to this side of the brain and this side of the brain. So it's crossing both over. The optic nerve is sending that message in to this side of the brain and that side of the brain. And what's happening is that's causing cranial nerve 3, ocular motor, to actually send the signal of the pupil constricting, and then again, consensual, that pupil's constricting. So again, the sensory information is being carried to the brain, and the blue is the motor neuron carrying it out. So when you check that the pupils are reactive to light, that's what you're checking. So you're going to go in, you're going to do that. I had a student one day on clinical that wrote pupils equal Perla. And I said, okay, tell me what happened when you did the light reflex. She said, well, I didn't have a pen light. How did you check the light reflex? Yeah. Accommodation is adaptation of the eye for near vision. So what happens in this case, you're actually taking, you can use your pen light or you can use a pencil, and what you're doing is you're watching, the patient is watching the object go in, and then your pupil should go in towards, sometimes my eye is lazy, so it might not work, but you can actually see right in this picture. You're adapting the eye for near vision. So you're bringing the object close to their nose, and their eyes should follow it. So you see the eyes both go in to the follow the object. So they're both looking towards the nose. And what happens as well is that the pupils usually constrict when this is happening. So this is what's called accommodation. So again, accommodate, the adaptation of the eye for near vision. So it converges towards, the motion is that the eyeballs will move and the pupils usually constrict. So fixation, a reflex direction of the eye towards the object, attracting the person's attention. This can be impaired if they've had drugs, alcohol, if they're fatigued, they're not paying attention. And you can only test for accommodation if your patients are awake, because they have to follow directions. You have to say, follow this object as I'm showing it to you. Once again, I used to have patients in the intensive care unit that would be in comas. Students would write Perla. And I'd say, oh, did the patient wake up just for this test and then go back into the coma? So they have to be alert to do this. So when you record pupils equal, reactive to light, and accommodation, this is what you're checking. So just be practicing this on the lab, because it's nice to see it actually work. Okay, so let's talk about some internal structures and functions of the eye. We have the most internal structure of the eye, which is the retina, which is formed from the optic nerve. So optic nerve, cranial nerve 2, that's what actually helps us see. So the optic nerve comes into the brain, comes in from the brain structure and forms and helps form the retina. You cannot regenerate the retina because it's made of neurons. So if you damage the optic nerve, it cannot be regenerated. So what happens is the retina actually converts images from the brain that you can actually understand it as vision. So it's the innermost layer of the eye, the sensory portion of the eye that changes light waves into neural impulses to travel to the brain for interpretation. It's actually fed by blood vessels, both venous and arterial, that lead out of the optic disc, and it perfuses the retina. They can be visualized on eye exam. So this is kind of cool. This is the only area of the brain. So let me review this again. So this is your optic nerve right here, and you can see it again. The optic nerve is coming out, and it's perfusing. This whole area right here, is your retina. So when the optometrist or ophthalmologist is looking in the eye, he's looking at this area of the retina, and he's looking at the veins, and he's looking at the arteries. So again, this is the only area of your body where we can, with naked eye or the ophthalmoscope, visualize actual vessels. So we can do it from arteriograms in our legs and heart and stuff, but this is where you can actually see vessels in the eyes. And this is where people that have like high cholesterol and high blood pressure, if their vessels are clogged in their heart and their legs and other places, they're usually clogged in their eyes as well. So that's why they want to look at all these vessels. And again, this is something that the ophthalmologist is doing, or a nurse practitioner that's trained in this. It's really not something that you as a student are going to be examining the blood vessels in someone's eye, but it's good to know what we're actually looking at. So once again, all this is perfused by the perfused into the retina. So this is just a bigger picture of the retina. So this whole area is the retina. And what they're looking at when they look in is they're looking at what's called the optic disc. So the optic disc sits back here, the optic disc, and it's comes out of the optic nerve, and it's a circular, clearly defined disc. Okay, so this is important. The optic disc is normally yellow, and it has clearly defined borders. Blood vessels come out of the optic disc and perfuse the retina. So when they're looking in your eye, they're looking at this optic disc to make sure it has nice, clean borders, that all the vessels look good coming out. So once again, here's a better picture. This is the optic disc. There's a physiological cup that sits inside that's important, but basically I want you to try to understand the optic disc. It's nice, clear borders. You can see the veins and the arteries coming out of it. This is the macula back here that's responsible for central vision. So what I want to explain to you is this is just a better picture of this retina and the optic disc. So your optic nerve comes right out of your brain here, and it perfuses the retina. So the optic nerve leads into the optic disc and perfuses the retina. Okay, so here's your brain here. Here's the retina, and the retina takes all that information and it sends it back to your visual cortex, which sits in your occipital lobe. So this is all what's responsible for vision. So again, your brain's sending this out, the optic nerve. So when a physician looks in your eyes, or an optometrist or ophthalmologist looks in your eye, he'll put a ophthalmoscope in, and he'll look inside and he'll look back and he'll see the optic nerve, and he'll look at that optic disc and he'll say, okay, this looks good. It's a normal retina. I can see that the disc is brown. It has vessels perfusing it. Now, recall that retina is fed through this optic nerve. So let's say you have a patient or a family member or something that fell off a ladder. I'll use an example. There was a guy one time that came in the ER that was washing windows, fell off the ladder and hit his head and was knocked unconscious. One of the things they do in the ER is they look with the ophthalmoscope because they want to look at this optic disc, okay? Because what happens if you have increased pressure on the brain, so let's say the brain is pushing down on that optic nerve and not allowing it to be perfused, what happens is that optic disc that's supposed to be nice and circular and clear borders becomes bulging, and it doesn't have nice clear borders. Like, look at that optic disc. So they'll look back here and say, this patient has what's called palpal edema, because the brain is putting pressure on that optic nerve. That optic nerve is not perfusing like it should, and you'll look at that optic disc and it'll be bulging. So again, not something you're going to do, but it's something that's good to know and interesting, I think. The other part I want to talk to you about is what's called the lacrimal gland, because this is something important that nurses should know. So this is actually in the upper outer corner of your eye, and it secretes tears. So if you look at this picture, here's your lacrimal gland. It secretes tears into your eyes. It goes down the lacrimal sac and into the turbinates of the nose and eventually out of the body. So this just, again, tells you tears wash across the eye. They're drawn up evenly as the lid blinks. They drain into the puncta or upper lower lids. Not really important to know, but they go down to this lacrimal sac and then eventually empty inside the nose. And, you know, if there's too much drainage, will come out that way. But the reason I want you to know this is because when you give your patients eye drops, or you take eye drops, or you're teaching your family members how to use eye drops, you want the eye drop to remain in the eye. You don't want it going out into the nose or, you know, getting out into the systemic circulation. So one of the things you always do when you give someone eye drops, after you instill the eye drops, you should be putting pressure on that lacrimal sac right here. So you should be actually putting pressure so that, just for a few minutes, so that the eye drops stay within the eye. And I can remember that was an NCLEX question one year, that what should you do actually at pressure right here. Okay, so extraocular muscles. So there's 6 muscles attached to the eye in its orbit and directs the eye to point in whatever way we ask the person to point. So it can look this way, out that way, down, and down. So again, it's a rectus muscle, superior, inferior, lateral, medial rectus muscles. And when I showed you the first picture about the lazy eye, it could be like a muscle problem, that maybe one of those muscles isn't strong. And all these muscles kind of work together and have our eye coordinate in different areas. So actually, here's a picture. No need to remember all this, the names of these muscles, but this is what you check. And you'll be checking this in lab as well. It's called extraocular movement. So you would ask your patient, okay, follow the pencil here with both eyes, keeping the head still, follow it down here, down here, down here, down here, the 6 cardinal moves in the direction of the eye. So what are we checking when we're checking extraocular muscles? So again, we're checking the movement of the they're stimulated. The extraocular muscles are stimulated by cranial nerves. So once again, I'm bringing cranial nerves back in because we're going to be getting them next week. So if you think about it, your cranial nerves help control these movements of your eye. So you have cranial nerve 3, 4, and 6 that control the movements. So what I want you to remember is cranial nerve 4, cranial nerve 6. Cranial nerve 4 is telling the eye, look towards the nose, look towards the nose. Cranial nerve 6 is telling, no, look towards the ear, look towards the ear. So think about it this way. 6 and 4 are in a tug of war. So 6 is saying, look towards the ear, look towards the ear. And 4 is saying, no, 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 look towards the nose, look towards the nose. So they're basically both fighting in this tug of war. So if your cranial nerves are all functioning and everything's normal, your eyes should be looking straight ahead because they should be of equal strength. So cranial nerve 6 is saying look this way, cranial nerve 4 is saying look this way. And 3 is responsible for all the other movements in the eye. Okay, so I'm trying to remember which one I'm talking about. All right, and I'll revisit this again next week, but think about it. Cranial nerve 4 is saying, look towards the nose. Cranial nerve 6 is saying, no, look towards the ear. So look at this patient. His one eye is looking straight, but this eye is looking towards the nose. So what nerve is damaged? Cranial nerve 4 or cranial nerve 6? So think about this. They're both in a tug of war all day. 6 wants you to look this way. 4 wants you to look this way. So when you look at someone, now again, this could be a muscle problem. So if somebody's cross-eyed, you're going to the mall, don't say, oh my gosh, they have cranial nerve damage. It could be something different. So, but if we're just assessing cranial nerves and we think that this person may have a cranial nerve issue, 6 wants you to look this way. 4 wants you to look this way. So what nerve do you think is damaged here? Do you think 4 is damaged or 6 is damaged? It's actually 6. Because think about the tug of war. 4 won the tug of war. That's why the eye is looking towards the nose. It would actually be looking down a little bit. I couldn't find a great picture. But again, we'll revisit that, but kind of important to know our cranial nerves. Okay, so moving on to the internal anatomy of the eye. So your eye has an outer fibrous layer, your sclera, which is the white part that we can see, a chorion, the vascular layer, and then the inner layer is the retina, which is what we talked about already. The retina has a vitreous body. Only parts of it can really be seen with the eye exam, but we can look at the sclera with our naked eye. So once again, here are your layers. The retina is what sits in the middle, and then the chorion is the middle layer, and the sclera is the outermost layer. Oops, sorry. So again, the sclera is tough, white, protective covering. It's smooth, transparent, covers the iris and the pupil. The cornea is the part of the refractory media of the eye, bending incoming light so that we'll focus on the retina. Sensitive to touch, and this is your cornea, and you may have heard people that have had like a teared cornea. So the stimulation, like the wisp of a cotton is usually how they check it. We'll check the corneal reflex. And again, I'm just going to introduce a couple more cranial nerves since we're going to be having them all in neuro. The trigeminal nerve is actually the nerve that innervates your face. So that's like a sensory nerve. So when we touch the face, we check the cranial nerve. That's cranial nerve 5, which again sends afferent sensations. So afferent's usually sensations coming in. So if you're checking cranial nerve 5, you can do these wisps down the face. The facial nerve is cranial nerve 7, and that carries an efferent message and is a motor neuron. So again, here they are. So cranial nerve 5 is trigeminal, and that's a huge nerve. That innervates the mandible, the maxilla, all the way up here. So it's this part of your face, this part of your face, this part of your face. So that's all the trigeminal nerves. I don't know if you've ever known anyone that has trigeminal neuralgia. It's very, 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 very painful. So one of these nerves is being compressed, one of these sections of the nerves, or it could be the whole nerve. So this is sensory. Like I said, we'll check it. Cranial nerve 7 is the facial nerve. And this is when we tell the patient, blink really hard. You get both eyes to blink and try to open them. This is the motor nerve that's actually able to keep that blink. So again, that's cranial nerves 5 and 7. So we're getting through them. So the inner layer of the eye is the chorion. It has a dark pigment to prevent light from reflecting too heavily into the retina. And the iris is that colored part of your eye, and it also controls the amount of light. Muscle fibers in the iris contract and helps the pupil with bright light or accommodate to near vision and far vision. The pupil is round, regular. Size is determined by the balance between the parasympathetic nervous system and the sympathetic nervous system. So if we stimulate the parasympathetic nervous system, it constricts the pupil. So remember, the sympathetic nervous system is fight or flight. So if, somebody's holding a gun to your head, you're going to be in fight or flight mode, right? You're going to want to run out of here at any point. That's when your sympathetic nervous system gets stimulated. And when that happens, your pupils are big and dilated. So if right now you're looking at your pupils, hopefully you're not in a total panic state. You're just kind of relaxed like I am, sitting here talking. It's your parasympathetic nervous system. So that's why most of the time your pupils are constricted, because it's your parasympathetic nervous system, just the one that's just kind of like the normal body functions that happen. When the sympathetic branch takes over, that's when your pupils are like dilated, like you're ready to run, run out of here because somebody's chasing after you with a gun. And also light can change the size of the pupil, as we saw in the first slide. So the lens is a disc located just posterior to the pupil. It's transparent and it serves as a refractory medium, keeping a view of objects in focus. So the thickness is controlled by the ciliary body. The lens bulges, focusing on near objects, and flattens for far objects. That's going to be important only because when we talk about changes in the elderly. So if you look at this picture, think of your lens as, your lens is right here, and your pupil opening is right there. So the lens kind of expands, it kind of like stretches out when it's relaxed, and that's when our pupils are dilated. And then it also comes in closer, like accommodates, so it kind of changes shape so that we can see things near and far. So your lens, again, it bends depending on what light rays are coming in. It changes its shape. Let me just go back here. Also in the eye, we have aqueous humor, which is produced by the ciliary bodies right here. So the ciliary bodies produce aqueous humor, and it comes in and out of your eye. Again, we'll talk about that with different diseases in the elderly. So, okay, so let's go here. So the retina is, again, I'm sorry, I'll do this one more time. So again, your lens changes shape depending on if the objects are near or close, if there's light in, so it accommodates to all that. Again, the inner layer of your eye, we already went through this, is the retina, and it's where the light waves are changed into nerve impulses. And we can see it through the optic disc. The optic disc is the area which converges from the optic nerve. This isn't really, that's just kind of saying what I already said, where the optic disc is. Okay, so let's do a little summary of what we need for an eye exam. So we've already inspected the external structures that we can. We inspect the eyeball and the sclera. We can check the color. If there's bloodshot eye, we can inspect the ocular fundus. Now this is where you're not going to do this. This is done by an optometrist or ophthalmologist. That's when they're looking at the optic disc, they're looking at the vessels, they can see the macula, all the vessels, especially if somebody has high blood pressure, diabetes, this is where these vessels get damaged. But again, you've seen that the reason that they're doing that, like when that palpal edema. Testing visual acuity is the Snellen and eye chart. I'm sure you've all had this done when you were in school, if you've never seen an eye doctor, with the big E and all the letters. We usually don't do that, but that's something you need to know. Snellen eye chart would check optic nerve 2, which is your cranial nerve 2. Testing visual fields, checking central and peripheral vision confrontation tests. I don't think I went over that, but I will. And inspecting the extraocular EOMs, the extraocular motor function. So that's cranial nerve, remember all those cardinal movements. Cranial nerve 6 makes you look this way, 4 is this way, and then 3 is all the other movements. So you're going to be able to check that on your lab partners. Visual fields is actually checking peripheral vision. So that's when we, again, you'll be doing this in lab, where we bring the fingers from the back and say, when do you see this? Because your peripheral vision obviously is here. So we ask the 6 movements where the visual fields come in. I don't know if I have a slide on that again. So again, testing central vision is the Snellen eye chart. It's the most common thing used. It's an accurate measure of visual acuity. It has lines arranged in decreasing size. So you put the chart in a well-lit spot, and you put the patient exactly 20 feet from the chart. And the chart is aligned with measurements there. If your vision's 20/20, that means when you're standing 20 feet from the chart, you should be able to read at the line that says 20. So if the person wears glasses, you usually have them wear their glasses. And again, you want to try and encourage them. That's why some people might have like 20/15 vision, that they can even see better than what it is. Okay, changes with the elderly. This is what you need to know, is that the pupil size decreases, the lens lose their elasticity. So remember I said the lens kind of changes shape. It either gets wider or it becomes more concave when it's focusing on near and far away objects. When you're elderly, the elderly lose that elasticity and the lens becomes hard and glass-like. So it decreases its ability to change and accommodate for near vision. So this is why the elderly, and elderly I mean over the age of 40, have what's called presbyopia, which is normal. That means if you gave them a book to read like this, I actually have my prescription glasses on right now, they wouldn't be able to read it. That's why the elderly, like myself, carry readers at all times. So presbyopia is a normal change that happens with elderly. So you need to know that presbyopia. By age 70, the normal transparent fibers of the lens begin to thicken and yellow. And this is what we call cataracts. So that happens a little bit later, about the age of 70. And visual acuity may be diminished gradually after the age of 50, and then more so after 70. Also, night vision decreases as we age. So, okay, this is presbyopia. So here you go. This is the normal eye. You can see the pupil size decreases, the lens loses its elasticity, and decreases the ability to change shape to accommodate for near vision. So again, when they're looking at the normal eye, they can see that the light comes in, the lens changes its shape. So that's what your physician's looking at. When the eye has presbyopia, the lens is hardened. So that area right there, it can't change its shape, and close objects are no longer focused clearly. So this is what you have to look forward to when you get older. I've gone out to dinner and, forgot my readers, and I can't even read the menu. It's like I'm looking at it and I have to really strain. So hence why all of us over the age of, usually starts about 40 to 50, pretty much for sure. So normal, know that this is a normal change in the elderly, presbyopia. Other developmental things that happen as we age that decrease visual acuity are cataracts. So cataracts start to form on the lens. So protein deposits kind of start to deposit on the lens when people have cataracts. And normally, when we're younger, we can kind of shed those protein linings. But in cataracts, I'm going to keep cataracts up there for a minute and show you this. With cataracts, the lens of the eye develops excessive layers of epithelium, and we lose the ability to degenerate, and it accumulates and proliferates. So that protein fibers just begin to clump, and you start to have this cloudy appearance on the lens. So they can actually see the early makings of cataracts. I don't have any symptoms right now of cataracts, but when I went and got my eyes examined, she said she could start to see it to build up. The cataracts are starting to build up in 52. So here's the normal eye. Almost the eye with the cataract, and you can see this. It looks a little like a buildup, or kind of like glass-like. So if it's really obvious, you can look at your patients and see it. So once again, inspection. I can look at that and say, something doesn't look right with that eye. You might not be able to diagnose it as a cataract, but you can say it doesn't look like what the normal eye would look like. Another thing that happens is glaucoma. And glaucoma is an increased intraocular pressure. I think I have a slide on this. Okay, so what happens in glaucoma is we normally have in the ciliary bodies, I'm going to go back to this slide 1 second. The ciliary bodies right here make aqueous humor. So you know your eye has fluid, and the aqueous humor comes in and it gets drained out through this. There's a picture of it, but there's a trabecular meshwork where the fluid gets drained out. You don't need to know that, but just wanted to tell you what happens in glaucoma is okay. In glaucoma, what happens is that fluid gets built up, so that aqueous humor is not drained out. And what happens is it starts to build up in the eye. So again, the fluid doesn't get drained out. It starts to build up in the eye, and it can put pressure on the optic nerve. So the problem with glaucoma is it's common. It's something that can happen as we get older, but we have no symptoms until we've damaged that optic nerve. Okay. So remember, I said when we look at the let me go back to this picture. Remember, the retina is responsible for our vision. So the optic nerve's here. So if we keep increasing and increasing the amount of fluids within the eye, it's going to start to put pressure and damage on that optic nerve. So in glaucoma, we don't know this is happening until that optic nerve could be damaged, unless we're getting regular eye exams. So if we damage that optic nerve, we can't regenerate it, so they can lose their vision. So it's devoid of symptoms. So in other words, we have no symptoms until significant irreversible optic nerve damage has occurred. So typically what happens is they have gradual loss of their peripheral vision. So once again, glaucoma is increased intraocular pressure, usually not painful unless it's a certain type. Macular degeneration is the breakdown of cells in the macula. And remember I said the macula is responsible for central vision? So they lose central vision. That's what happens. They're not able to do fine work, or like they won't see things, be able to, well, they can't read fine print anyway, but maybe sew or do any kind of fine work because they've lost all that central vision. I should have really put that line in there. Okay, so you got cataracts, so you got glaucoma. And again, we can check for glaucoma, and people should all be checked when they go, because you can actually treat glaucoma with medications. So when you're doing your history on your older adults, you want to say, have you noticed any visual difficulties, climbing stairs, anything with night vision? That's kind of things that are going to happen anyway. When was the last time you were tested for glaucoma? Again, remember I said they don't have symptoms, so if they're getting their eyes checked, glaucoma should be something that they're getting checked for. Any pain around your eyes? Are you losing peripheral vision? Any history of cataracts? Are you having blurring vision? Because they actually, I remember when we were in the nursing home, they would actually have us put Vaseline on glasses and tell you that's kind of how they're seeing with cataracts. Do you feel any numbness or burning? Have you had any decrease in your usual activities? Okay, so now we're moving on to kids. Peripheral vision is intact in the newborn. The macula, which is your keenest sense of vision, is absent, but it matures about 8 months. By 3 to 4 months, they can fixate on a single image with both eyes at the same time. So developmental eye exams usually deferred at birth, because with infants, they're usually giving them prophylactic ointments. So usually there has edema on their lids after birth, so they usually put silver nitrate. So they usually give their eye exam maybe a few days after birth. You kind of look at this baby, like just kind of, again, examine their eyes. You can usually tell Downs babies usually have like a slant kind of upward. Their eyes kind of slant upward. So additional history for infants, any vaginal infections that the mother may have. Consider the age of the child, so think about the milestones. Have they had routine vision tests at school? Schools are always doing vision tests. Make the parents aware of safety measures for their child, that their toys are appropriate age. Have they taught that sharp objects, they should not be used to carry, not to carry sharp objects, or how to carry sharp objects. And I kind of like this part, subjective, since you're going to be writing on your health history, subjective data. Vision reported good with no recent changes. So again, subjective, this is all what the patient's reporting to you. no eye pain, no inflammation, no discharge, no lesions, wears corrective lenses. Vision last tested 1 year prior to admission. Test for glaucoma at that time was normal. If we're looking at objective data, so this is when we're doing the Snellen eye chart. Right eye, left eye, 20/20. Fields are normal by confrontation. Corneal light reflex is symmetric. Diagnostic position test shows EOM, so extraocular movements are intact. Brows and lashes are present. No ptosis, which means like drooping eye, where nystagmus is also, I forgot to mention that one, is like the flickering of your eyelids. So we'll go through that. No sclera is right, no lesions, and perla. So they're writing all this in their objective note. Again, this is more for the optometrist, talking about the margins and the vessels within, but it's, you know, something you could read. No hemorrhage, no papilledema. So assessment, healthy vision, healthy eye structures. So again, you've done all these assessments and you determine healthy vision, healthy eye structures. And once again, an office. So I will be here to answer any questions. I'm sure you're not going to look at this material until after we get through test 1. So this is on test 2. When we meet back for our next lecture, which would be October, I think, October 1st, which is a Monday, I'll be doing neuro and mental status. So I will answer questions about this lecture if you have them at that time. So thanks. And at this point, you haven't taken your tests. So I'm hoping that you all do well. So take care and happy study.